This episode of the Jerry Paul Podcast is CME eligible.
To claim credit, please go to the CME tab on jerrypal.org.
Welcome to the Jerry Paul Podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, who do we have with us today?
Today we are delighted to welcome Adriane Fugh-Berman, who is professor in the Department of Pharmacology and Physiology at Georgetown University Medical Center in the Department of Family Medicine, and also founder of PharmedOut. Adriane, welcome to the Jerry Paul Podcast.
Happy to be here.
We're also delighted to welcome back Alexis Colley, who is a resident in surgery and a palliative care fellow at UCSF. Alexis, welcome back to Jerry Pal.
Thanks for having me.
So today we got I love this topic, how pharma invents diseases. So we got a lot to talk about with pharma influence on medical providers, prescribing, a ton to talk about. But before we jump into that topic, we always ask for a song request. Adriane, do you have a song request for Alex?
Yes, I would love to hear 50 Ways to Leave Drug Companies.
Now, I haven't. Is that a Beyonce song?
No, it's a parody of a Paul Simon song, of course, 50 Ways to Leave Your Lover.
So you wrote the parody. Alex usually writes the parodies, but this is a new one where we have a guest write the parody.
I love it. This is a guest-written parody. This is great. This will be fun. Here we go. The problem's over-promoted meds, she said to me. You know we've got to treat our patients carefully. I'd like to help you to become pharma-free. There must be 50 ways to leave drug companies. She said it isn't education that the reps provide, and what they know about you they're unlikely to confide. What they want to do is control what you prescribe. There must be 50 ways to leave drug companies. 50 ways to leave drug companies. Have the reps take a hike, Mike. Buy your own pen, Jen. Don't need a free meal, Neil. Just get yourself free. Throw away your samples, Kay. Don't have to use new drugs. Pay your own CME, Lee, and get yourself free.
We got more of that song at the end of the podcast, so get ready for it.
That was wonderful.
So we got a lot to talk about, again, on the influence of pharma. We're going to talk about devices, too, on physicians, on providers, how they prescribe. And you've had a long research career, a lot of influence in this regard. What's your origin story? How did this all start for you?
Well, I started off as a women's health activist. I worked in reproductive health clinics, and I was very involved with the National Women's Health Network, which is a consumer advocacy organization that does not take money from drug companies or other industry. So we had been working against medicalization of menopause and medicalization of childbirth and medicalization of other normal life states. So I'd been doing that for quite a while before I decided to go to medical school. So I was always an activist. And later, so I went to Georgetown, then to the residency program in social medicine at Montefiore, where I did internship, and then eventually went to work for NIH, worked as medical director of several alternative medical clinics, and then came to Georgetown. So let's see. So I guess more than 15 years ago, the attorneys general of the highest lawyers of every state created a grant program, the Consumer and Prescriber Grant Program. It was funded by punishment money from a drug company, Warner Lambert, which was a subsidiary of Pfizer. It was punishment money for off-label illegal promotion of a drug called Neurontin. And
just for our listeners, too, if you want to learn more about that, we did a gabapentin super special a ways back where we talked a little bit about how gabapentin rose in fame. I think it's in the top 10 drugs as far as prescribing still to this day, likely because of side effects of this off-label push by drug companies to physicians.
Very interesting. I'm so glad you covered that. Yeah, so they funded a number of academic medical centers and organizations to create educational modules on pharma influence. And so PharmedOut, or what we weren't farmed out at that time, but what became PharmedOut was funded through one of these, and we've been going strong ever since. In fact, once the grant ran out, none of the people who were working with us quit. Even our work study student continued to work for free after our grant ran out. And so we started to just ask friends for money, and we're still mainly supported by individuals, and we've been doing great work.
What's the mission of PharmedOut?
Well, we've
current
got,
mission.
So I think our main mission is to get pharma out of education, out of medical education, out of continuing medical education. We want a complete separation between industry and education of any healthcare providers.
Why?
Because pharma doesn't have objective information to give. And the idea that we're partners in this, that healthcare providers and pharmaceutical companies are partners, is a false concept or a lie. And of course, pharmaceutical companies are beholden, they are legally obligated to represent the best interests of their shareholders. Yeah. And we as physicians and healthcare providers are legally required and ethically required to represent the best interests of our patients. Those are not the same thing. And what we're particularly interested in is the covert means of promotion. So not just the drug reps and not just the advertising, but the covert influence on medical journals, on medical meetings, on patient advocacy groups, on medical societies, all of this use of third parties to put out marketing messages that they may not even realize are marketing messages.
Yeah. I guess I'm going to start off with the devil's advocate position, because I actually agree with you, but I'm going to be the devil's advocate here. You know, it takes well over a decade for something to become the standard of care. I think that was the party line. It takes a very long time for a new beneficial thing to really be changed in clinical practice. And, you know, from a drug company's perspective, if they have a drug that works, isn't there a role for sharing and educating physicians that this drug is out there, it works, it's going to benefit your patients?
I think the study that you're thinking of actually showed that after something has been proven to either work or not work, it takes 17 years to change practice. But that's when it's been proven to work. The thing with pharmaceutical company promotion is that it's most active with drugs that don't work or are harmful or are very expensive. There's an inverse relationship between how good a drug is and how much promotion is provided, which makes sense, right? If you're a drug company that has the cure for pancreatic cancer, you don't need to sell that drug. We're going to be talking about it at medical meetings. There's going to be all this buzz that clinicians are going to generate about it. But if you've got the 6th or 7th ineffective drug for a particular condition on the market, you're going to have to promote the heck out of that in order to get anyone to use it. And they're very effective at changing practice quickly.
That's fascinating. Not a lot of ads I see for Ozempic out there. Is this a story, a tale as old as time? Has this been something that we've seen for decades, century in medicine, or is this like a new thing?
Oh, that's an interesting question. So our topic today is invented diseases, and I think that probably one of the first diseases to be invented for profit was invented by Arthur Sackler.
I've heard that name before. Of Sackler fame. Sackler opioid. What's the drug companies? Starts with a P.
Purdue
Pharma. So the Sackler family is most connected to OxyContin, but as Arthur Sackler's widow likes to point out, he wasn't around during OxyContin. But it can be argued that Arthur Sackler actually had much more of an effect on medicine because he actually created the idea of using education as advertising, and he started IMS, which is now IQVIA, which is a health data mining organization. They're the ones that track all of our prescriptions. They buy that information from pharmacies. And by the way, all of your medical records are also sold to pharmaceutical companies.
What?
Pharmaceutical companies know what diseases you have, your allergies, last time you saw a physician, when you go to the hospital, your zip
How is
code,
that
your
legal?
body
Isn't
mass
there
index.
like HIPAA?
As long as you're identified by number and not by name, it is anonymized patient level data. And it's HIPAA compliant. So there are companies that will take this information and combine it with prescribing information in order for companies to be able to tailor their pitches to physicians when drug reps go into their offices. So when a drug rep goes into a physician's office, that drug rep knows exactly what antihypertensive that physician prefers for their patients over 70 years old, for example.
And how well their marketing is working for that particular physician, or
Exactly.
that free lunch is working for
Wow.
that particular physician.
But back to Arthur Sackler. So he invented some marketing techniques that he's a brilliant marketer. He's in the Medical Advertising Hall of Fame. He was a brilliant marketer. And he was hired at some point by Roche, which had a sedative called that became was Valium, but they previously had a sedative called Librium, and they didn't want sales of Valium to cannibalize sales of Librium. And so the idea that Arthur Sackler came up with is to cast Valium for a different indication, if you will. So he invented the idea of psychic tension, and that way Librium could be sold for generalized anxiety disorder, garden variety anxiety, but Valium would be sold for psychic tension. And psychic tension was the discomfort that someone might feel on getting married or going to college or moving. So normal kinds of life stresses that anyone might have. And Valium was the first blockbuster drug. Brilliant marketer.
Yeah, it was amazing how many people were actually taking Valium, looking at the history of Valium over time, and
Yes.
who it was targeted towards, which was heavily gender-based. Is that right?
Yeah, absolutely. Very much targeted towards women.
Is that still a theme? Because it feels like, I mean, aside from, we'll talk about like low T and testosterone, but it feels like there is maybe a gender influence there too. Is there one?
Well, there are many things that are targeted mainly towards women, and I'll say one thing that has really come up lately is there's been a resurgence of casting menopause as a disease, and so that's something that we are going to see more of in the coming years. And this is really sort of a tragedy because feminists worked hard during the 60s and 70s to stop the medicalization of menopause and pregnancy, and to elucidate that the only symptoms that have been proven to be related to menopause as opposed to aging are hot flashes and vaginal dryness. And of course, estrogen was promoted very much between the 60s and about the 2000s until
I remember in med school. I went to med school 98, 2002, and
right?
hormone
Hormones for
replacement
everybody.
fixes everything. Everybody should be on it.
We thought it prevented cardiovascular disease. We thought it prevented dementia. We thought it prevented strokes. We thought it prevented incontinence. And then the HERS trial, which was done in women with pre-existing heart disease, and then later the very large definitive trial, the Women's Health Initiative, which was done in healthy women, showed us that the harms of menopausal hormone therapy outweighed the benefits, and that it really should not be used to prevent any disease, that menopausal hormone therapy increases the risk of cardiovascular disease, stroke, breast cancer, ovarian cancer, deaths from lung cancer, and also dementia. Dementia, mild cognitive impairment, it actually causes some brain shrinkage. Anyway, and certainly for severe menopausal symptoms, the only two of which are hot flashes and vaginal dryness, it can be a reasonable choice, although women should be informed of the risks. But currently, just in the last year or two, there has been this resurgence of, there's a stigma around menopause. Women can't talk about it. Workplaces need to be sensitive to it. Bosses need to hire menopause coaches. The Women's Health Initiative, this myth has been perpetuated that the Women's Health Initiative was wrong, and that And really, women shouldn't be afraid of using menopausal hormone therapy to address the 10 or 16 or 32 symptoms of menopause, which include everything from brittle nails to weight gain and brain fog and all of these other things that many of us would love to find a pharmaceutical fix for. But
why do you think there was a
menopausal hormone therapy
resurgence
is
in the
not it.
last couple of years? Because I've definitely seen it. I've seen a lot more even talk on social media about the importance of thinking about hormone replacement therapy. I think there was something just published in one of the medical journals this week about it too.
Yes, JAMA just this week published a review by some of the Women's Health Initiative investigators that just pulled together some of the information about the trial, including the fact that there were fewer adverse effects in women in their 50s. Of course, there were fewer adverse effects in women in their 50s. Women in their 50s have a low rate of heart attack and stroke, et cetera, to begin with. There's going to be less risk of any disease in women in their 50s rather than women in their 70s, for example. So the review itself doesn't break any new news, but the way it was reported by media was just terrible, which was, which was saying that, this new study has found that everything we knew about menopausal hormone therapy was wrong, and it's really fine for everyone to take it. It was really terrible coverage, terrible.
So I guess another question is, again, this is kind of like it's not really an invention of disease, right? Like menopause is menopause. I guess you can argue it's not a disease. It's natural part.
In fact, it's a really artificial designation.
Yeah.
Menopause is when you've gone a year without having a period. You don't even know when menopause is. The only thing you could actually celebrate is the 1-year anniversary of menopause, right? Because you don't know with any period whether that's going to be your last.
Yeah.
So there's no real medical distinction for menopause. And of course, if you just throw in any condition that has to do with aging or has to do with life in there,
low testosterone, low T.
Low T. And by the way, testosterone is now also being pushed for menopausal women, like added on to the estrogen. Well, there's no such thing as a harmless hormone. And low T was pushed a number of years ago. There's been less of a push recently, perhaps because the FDA the FDA actually changed the label on testosterone, which makes it harder for companies to push it for low T. Or, of course, they always have like the medical name. So low T was what they called it to consumers, but to clinicians, they called it late onset hypogonadism.
You gotta. How do we technify that up?
And certainly with low T, it was really exactly like menopause. Like, is your sports performance less than it was 5 years ago? Yeah. Do you ever get tired after dinner? There anything with an online questionnaire. A lot of these invented diseases have these online questionnaires that are designed for people to fail. Like we gave the low T test to anyone who walked into my office over a period of several days. And, even the 25-year-old women failed it.
A lot of what you're talking about reminds me of like Noam Chomsky's manufactured consent. This idea that these drug companies are creating conditions and then marketing them to consumers in order to sell their products. I wonder if you were influenced by Noam Chomsky in your work.
Oh, you've got to love Noam Chomsky, and that's a really interesting thing to bring up because manufacturing consent is very much what pharmaceutical companies do with clinicians. They make it seem as though they're deferring to us and we are making our own decisions, but in fact, they're really manipulating us. And they also do this with consumers in consumer advocacy groups, which have become extremely important means for pharmaceutical companies to get their messages out. There are more than 7,000 consumer advocacy groups in the US, and there are fewer than 24 that are not funded by pharma.
Yeah.
We actually have a list of the non-pharma funded groups on the PharmedOut website because it's a lot easier to keep track of the non-pharma funded ones than the pharma funded ones. And the ones that take money from pharma are always up before the FDA or before Congress or before the media, backing bad drugs, for example. Anyway, And because marketing for a drug starts 7 to 10 years before a drug comes on the market, it's very difficult to identify. It's illegal for a drug company to market a drug before it's on the market, but it's not illegal to market the disease. And I'm sure that there is a company coming out with a low-dose estrogen product, maybe a transdermal estrogen product, because we're seeing a lot on, transdermal preparations, low-dose preparations will have all the benefits and none of the risks, which of course has not been established. Anyway, we're seeing, what we're seeing now with menopause shows that this is what industry calls a pre-launch marketing campaign. And so it's very difficult to identify the marketing messages when marketing starts up to 10 years before a drug comes onto the market.
So I got a question. So there is a big push right now in the aging space, in particular Alzheimer's disease, to relabel Alzheimer's disease as just having a positive amyloid test, whether it be a biomarker, PET scan, so a blood test. And that's being pushed by the Alzheimer's Association, a work group that was heavily dominated by industry. Like a third of the members are directly employed by industry. Another third have significant conflict of interests. And Alzheimer's Association gets a lot of money too from industry. Is that part of it too, where people are now thinking about like 5 to 10 years from now? We already have the biomarkers. Maybe we'll have like a drug that they can market. They have a drug right now they can market towards MCI and Alzheimer's disease. Do you see this as a similar phenomenon that's going on, or do you see this as separate?
I'm really glad that you brought that up, because what's happening in the Alzheimer's disease area is actually really horrifying. So, there are several of these drugs. So a population with Alzheimer's disease has more amyloid plaque, these sticky plaques in the brain, than a population without Alzheimer's disease. But many, many people, especially over 50, have amyloid plaque in their brains, and they have no cognitive deficits at all. Yeah. So there's not a clear link between amyloid and Alzheimer's, and in fact, getting rid of
unless you rename Alzheimer's as just or redefine Alzheimer's as just having amyloid, because then there's 100% accuracy.
Exactly. And what's really horrifying about what the Alzheimer's Association is doing is they're saying exactly what you said, like that Alzheimer's disease is if you have amyloid plaque that is assessed now, can be assessed by a blood test, even if you have no cognitive deficits at all. Like that is just
and may horrifying. Never have any in the future.
and you may never have any in the future. And of course, any of us who are over like 40 or 50 think that every time we forget our keys, it's like, we're on this, a downhill trend, a downhill slide. But I have to tell you, this is a wonderful thing about being a professor in a university and dealing with young people, because they have the memory of houseflies, really, but they're just not worried about it because they're 22, right? And those of us over 40 just think that, anytime we can't remember a name or whatever, that it's all starting. But these drugs are they're really not effective drugs at all. We've had bad drugs for Alzheimer's before. We had some drugs that we prescribed before, and I used to teach my students that these drugs only cause like a small improvement in symptoms. They have adverse effects. We probably shouldn't use them, but at least they caused a small improvement in symptoms. The drugs that are being promoted and are most widely used now cause no improvement in symptoms. They supposedly cause a small decrease in the rate of decline over years, which will not be apparent to either the patient or the patient's caregivers. And these drugs cause brain bleeding and swelling and shrinkage in a significant number of patients.
Yeah. Because it's interesting, because when Adriane came out, there was another one of these surveys, right, about memory problems, and I failed that one.
So did my 22-year-old students. It's okay. Mild cognitive impairment, of course, not only does it not usually progress, it's a very squidgy diagnosis. It does not usually progress to Alzheimer's, and it can change, when it's tested over time. And there's a great overlap with depression, and a lot of drugs can cause it.
But isn't that true for everything? Everything's a little squidgy, right? So I listened to several of your talks. You talked about cerebral affect, right? There are people who are suffering from pseudobulbar affect, from ALS or a severe stroke. And I've had one of those patients too who struggled with it. But that's a very narrow market and probably one you're not going to make a lot of money on. So that there's a push towards enlarging that market, just like enlarging Alzheimer's, not just people with MCI, which is incredibly hard to diagnose, but anybody with amyloid in their brain. Isn't that true for everything? Even like low testosterone. There are people who probably fall on that spectrum who have incredibly low testosterone that may benefit from those medications.
Yes.
Isn't this all about the squidginess?
Well, there are certainly some diagnoses that are more squidgy than others. There's a lot. The area in which there are the most invented diseases is in psychiatry, because every psychiatric diagnosis is subjective, right? We have no blood tests for psychiatric diagnoses. So there's a lot of invented diseases in psychiatry. So I'm not sure that every diagnosis is squidgy.
And then, oftentimes we're talking about not diseases, but risk factors that have been labeled diseases, like pre-diabetes. Pre-diabetes is a good one out there, where it's really a risk factor for a risk factor, which can cause significant.
Yeah, I have pre-diabetes. I'll disclose my health information.
You're going to name it as a disease.
And I have osteopenia. Just did what you think about that.
Sure. So with pseudobulbar affect, for example, that is a real condition, but it's very rare. And so expanding the market makes a lot of sense if you want to make more people eligible for drug treatment. Yeah. And one of the test questions on a test for pseudobulbar affect was, do you often find things funny that other people don't think is funny?
You laughed, Alex. That's a positive right there. That is not a funny statement, Alex.
Right? Yeah, so let's see. But you basically, anything that has pre before it, you should just ignore. Pre-hypertension, pre-diabetes. You know that pharmaceutical companies have had a hand in this. I remember in medical school, we were taught that a blood pressure of 120/80 was perfect. That was the goal for blood pressure. And now it's pre-hypertension. And of course, there are many more healthy people than there are sick people. And anytime you lower the standard, and they have been lowered in all of these cases, you lower the standard for what we call hypertension, what we call diabetes, what we call hypercholesterolemia. Anytime you lower those standards, you've made a lot more people eligible for drug treatment.
Yeah. And it feels like that, more than an invention of diseases, it feels like redefining diseases is a huge marketing focus of pharma.
Yes, absolutely. And yeah, pre-diabetes is a good example of that as well. You're under the limit of what would be considered diabetes. It may never change. Just ignore it.
Oh, good. I'll have the cookie after the podcast.
Well, I also think about my own experience as an internal medicine doctor, and over the years, pharma's influence on us. And I'm wondering, from a surgical perspective, Alexis, do you see the same from pharma or any other influences that come to your mind?
Yeah. I mean, I think, certainly as a trainee, we're under different circumstances sometimes. We don't have our own offices, but we certainly encounter device reps, surgical device reps, in our operating rooms every day. And I think it's an interesting topic because, they're very knowledgeable, of course, about their products, and they're often sort of practically helpful. Like your stapler gets jammed when you're trying to resect, part of the lung. And so they know exactly what to do under a very stressful situation. But I was wondering if you could talk a little bit about sort of devices and that aspect, maybe not so much farmed out, but deviced out, I guess.
Well, we do look at devices as well, and the regulation of pharmaceutical drugs really needs improvement, and we actually have a whole report on our site, a 140-page report on improving the FDA that goes into a lot of these issues. Well, there's a lot of regulation, a lot of problems with drug regulation. There's even more problems with device regulation. So for surgically implanted medical devices, companies can get a surgically implanted medical device approved without ever testing that device in a human. Most surgical devices are approved under a 510K or substantial equivalence standard, meaning that the device is substantially equivalent enough to a previously approved device, which may have been approved based on a previously approved device, and down the line, as long as you can show that you're substantially equivalent, you can be approved without ever being tested in a human. And while the relationships between drug reps and doctors are highly problematic, they're even more problematic between surgeons and device reps. Device reps are in the operating room. They are assisting the surgeon. They're not allowed to actually handle the tools or touch the patients, but they may be using a laser pointer to tell the scrub tech which tool to hand the physician. But they are there to help the physician and the team. Hospitals love them because they don't have to adequately staff their operating rooms with scrub techs who know what they're doing, but they are there to upsell product. They are there to sell, and of course, they're only selling one company's products. They will target the heads of residency programs, because if the head of a residency program only uses one particular company's hips and knees, that's what the residents will use. So it's a great investment. They bring the residents to trainings and get the cadavers for them to practice on, and they provide all kinds of services. So they have much closer relationships with surgeons than drug reps have with physicians, and it is highly problematic.
Yeah, that's really interesting. I mean, I think as trainees, we're not always aware of sort of the financial relationships between people who are educating us and who might be receiving reimbursement from these companies. But it's always been a fascinating tension, I think, because getting to know the reps can be helpful in some ways, because they teach you about different devices, and you're a trainee and know very little when you start out, but it's always seemed like this very interesting tension, also because they're just there in the operating room, and they're like a real person. So thank you for bringing that up.
They're nice. They're not evil. Like, I actually went to Boston to give a talk about geriatrics and palliative care to ACP audience, to general physicians. And afterwards, drug rep from Eisai, so one of the lecanemab makers, came up to me and talked. Super nice guy. Had a great conversation with him.
Of course they're nice.
Yeah. Right? That's
it's their job.
It's their job, but I think that's one of the tricks here, is that, like, part of this is that we think like we're good and moral people, and the people who accept these lunches, who go out to dinner, probably feel the same. Like, they're good people. The reps think that they're doing this for good causes. Like, most of them are not evil people that are trying to get that patient, but they're doing it to educate surgeons about how to use their devices. So we rationalize a lot of this. Mm-hmm. And I also wonder, and part of me feels like I am much more scared of the person who says, oh, that pharma dinner doesn't influence me at all. I am much more scared of them than the person says, I recognize that this has some influence upon me, and this is what how I think about it, and I'm doing about it, or I try to avoid it at all cost. And I just wanted to get your thoughts on that. Is just like the Alzheimer's Association, made up of great people, great mission. I don't think any of them are doing this for what they're thinking is a nefarious reason. They have rationalizations, just like the people who make up that work group. But man, I wish they would say, you know what? We are still human beings, and we're influenced by bias, and we're influenced by gift giving. We're influenced by money, and this is what we're doing to prevent that from influencing how this work group operates.
So it would be great if people were aware of influence, but there have been studies that show that that talks like the ones that PharmedOut gives, maybe similar to this kind of talk, that these kinds of educational interventions can convince physicians that physicians are affected by industry. Yeah. And yet it doesn't change people's individual minds about whether they themselves are influenced. So you can convince people that their colleagues are susceptible.
Not me.
Right, not me.
It's those weak-willed others.
As little as a $2 to $5 gift can influence how people's prescribing behavior.
Yeah, great study from Mike Steinman and Steve McPhee. This is back in 2001 of Principles and Pens, Attitudes and Practices of Medicine House Staff Towards Pharmaceutical Industry Promotions. Residents hold generally positive attitudes towards gifts from industry, believe they are not influenced by them, and report behaviors that are often inconsistent with their attitudes. Yeah.
Yes, absolutely. And we did a study. I did a study with Dr. Susan Wood at George Washington University School of Public Health of Medicare prescribers in Washington, D.C. And we found that taking any gifts from pharmaceutical companies, including just a meal, resulted not only in prescribing more branded drugs and more expensive drugs, but more drugs. People who took gifts prescribed 2.3 more prescriptions per patient. And of course, polypharmacy is a huge problem in our patient population, especially among elderly people. So it was horrifying to see that people were actually prescribing more prescriptions when they took blood pharma.
I also feel like I see less about gifts or like vacations to Hawaii, like in the 1990s or the 2000s, you'd have these big vacations but I see a lot more on CME. And the influence.
Great. I'm so glad you brought that up because, in most continuing medical education that physicians see is funded by pharma, and it always has marketing messages in it. Yeah. And whenever I say this, so industry will always respond to say, oh, no, there are 4 or 5 studies that show that there's no industry influence on CME. And I love the studies that they refer to because their studies always refer to, if you ask physicians after an industry-funded CME if they detected any influence, 98% say no. But in fact, every study, including a number, we've done most of them, every study that has actually examined whether there are marketing messages in CME have all found them. 100% of those studies have marketing messages. And they're hard to detect. Like if I look at one continuing medical education module on a drug, or I can't necessarily tell what the marketing messages are. But if I look at 6 of them, I can tell you. So this is how we torture our interns.
What are some examples?
Oh, well, for example, we did a paper on marketing messages in establishing the diagnosis of hypoactive sexual desire disorder or low libido in women, which is really not a medical problem.
Was there a survey for that too?
Oh, yeah. One of the questions that's asked on the Female Sexual Function Index, which is used by physicians to diagnose hypoactive sexual desire disorder, was how often do you feel sexual desire or interest? And in order to score the highest, you had to say that you felt sexual desire, interest all or almost all of your waking hours.
That was totally written by a dude.
So, of course, something that people would just fail. But so some of the marketing messages in the CME on HSDD was, well, often a very common marketing message for all of these things is it's a tragic epidemic. It's what we call the tragic epidemic. It's like, this is a far more widespread problem than physicians know, and it's much more serious than it is currently perceived. People might be unaware that they have it, so you have to elicit these symptoms with the questionnaires, which we so helpfully provide.
I'd also add there's pharmaceutical companies don't really care about diversity in their trials, but when it comes to marketing their messages, you hear a lot of equity issues come up.
Oh, absolutely.
Recently, in the last 3 to 5 years, it's always an equity issue, but never an equity issue when they're actually enrolling patients in their trial, which is mostly white.
I have a question about, and I want to see if Alexis has a question. How do we change this? And I'll just start by saying, oh, sorry, that's my pager going off.
Alex is getting called by Pharma right now.
Right. I'm a member, I'm a panelist for CTAF, which is a member of ICER, the Institute for, I think it's Clinical and Economic Review, which evaluates not just the evidence for effectiveness of new drugs and devices, but also the cost impacts. And sort of related to what you're talking about before, about the pharmaceutical sponsoring the patient advocacy organizations, we see that at our meetings all the time, where so many of the patient advocacy groups and the patient representatives are appealing, please approve this, and so many of them are part of organizations that are heavily conflicted and sponsored by drug and device industries. That said, ICER and the mechanism of evaluating this is sort of similar to what NICE does in the UK, is one lever to address this issue. I'd love it if you could talk more about PharmedOut and the mission of PharmedOut and how it will influence or should influence, ought influence, you hope it will influence this, and whether there are other levers that our listeners should be thinking about in order to affect change.
Yeah, so ICER is great. And doing comparative effectiveness studies of drugs and therapeutics is really important and something that is not required in the US. And something that healthcare providers can certainly do is to avoid relationships with pharma and with medical device manufacturers, not seeing drug reps, not going to industry funded events. And it's not just physicians, because a quarter of prescriptions these days are written by nurse practitioners and PAs, for example. So avoiding all industry-funded results and depending on unbiased sources of information from ICER and other places as well. So that's something that can be done. These patient advocacy groups are not required to disclose their conflicts of interest or their funding. The Sunshine Act, part of the Affordable Care Act, requires pharmaceutical companies to disclose their payments to physicians, and now MPs and PAs as well. They should be required to report their payments to consumer advocacy groups. There should be conflict of interest disclosures at every meeting in which these advocacy groups are. And legislators and regulators and media need to not be swayed by emotional appeals when it's really evidence that we should be looking for. There's a romantic idea that new drugs are always better, and they don't need to be adequately tested. And really, new drugs and therapies may make life more miserable and kill people faster. You don't know which one of those it is until you actually do a careful assessment through clinical trials.
Mm-hmm. Yeah. Alexis?
Yeah, I was just curious, sort of from the trainee's perspective, would you advocate, or is there any movement for programs or even schools of medicine to be more transparent with their trainees about what is sponsored, what's not? I was just at a recent cadaver course, actually, and I have no idea who funded that weekend. There were device reps present, but that sort of relationship was never discussed. Any thoughts about medical education and graduate medical education with all of this?
Yeah, I don't think there's much of a movement there. And there should be, that medical students and residents should be demanding that conflicts of interest be disclosed, but also that their education is free from industry influence. Doctors should be teaching each other. And some of the device reps that we interviewed for some papers that we did, who were medical students at the time and who are now physicians, they wanted to go into surgery, and both of them said they would never let a device rep into their operating room. And one of them said, if you're not willing to learn the equipment, find another job. So talking to people within industry gives you a really different view. Healthcare providers are being manipulated. I mean, as I said, PharmedOut is, we're really interested in these covert, these hidden methods of marketing, using third parties to convey marketing messages and being used to affect regulation, legislation, the approval of drugs and devices, and media perceptions of, particular diseases. So we all need to be fighting the medicalization of life. And please subscribe to our newsletter. We've got a podcast, Pharma Manipulation, as well.
And I just go to PharmedOut to subscribe?
Yeah, you can go to PharmedOut to subscribe.
Say the name of your podcast again.
And our podcast is Pharma Manipulation.
Great title.
Well, I want to thank you for joining us on the podcast. But before we leave, I think we have a little bit more of the song, the parody song.
And I love this parody song. The first line in the next verse is, she said it grieves me so that you're a KOL, capital KOL. What's a KOL?
A KOL is a key opinion leader or a nationally known influencer.
Okay. And what's an example of, so that would, this is talking about you.
Well, no.
No?
So KOL, it's an industry term for a nationally known influencer who can shape the perceptions of other healthcare providers. So usually somebody at a well-known academic institution who can, go out across the country and tell people that hypoactive sexual desire disorder is a horrible disease, that kind of thing.
I see. Okay. All right. Thank you. She said, it grieves me so that you're a KOL. Masking marketing as education doesn't serve us so well. I said, I resent that, but would you please explain about the 50 ways? She said, we owe it to our integrity. Together we can throw industry out of CME. And then she pinched me, and I realized she was probably right. There must be 50 ways to leave drug companies. 50 ways to leave drug companies. Join in. All right, here we go. Have the reps take a hike, Mike. Buy your own pen, Jen. Don't need a free meal, Neil. And get yourself free. Throw out the samples, hey. You don't have new drugs. They won't see immediately. And get yourself free.
Thank you for joining us on this podcast. That was wonderful. Encourage all of our listeners to check out PharmedOut and listen to the podcast. And thank you to our listeners for your continued support. And we'd also like to thank our donors who've donated more than $250, including
Nina Flanagan, Penelope Thompson, Lloyd Woolstat, Mark Wren, Carol Heyman, Bob Rixey, Patrick Lally, Matt Schuster, James Tulsky, Annie Hargadon, Jeffrey Galbraith, Daryl Owens, Meg Walhagen, Susan Nelson, Sharon Bragman, Harry Hahn, Jessica McFarland, Victoria Braun, Diane Meyer, Mike Steinman and Dorothy Richmond, Wendy Peltier, Kelly Strait, Craig China, Ron Saber, Rebecca Goldstein, and Elizabeth Chung.
And again, those are the ones who've donated more than $250 in the last year. If you're interested in donating, click on the little donate button. Or if you just want to share our podcast on other podcasting platforms or Twitter or any other social media sites, that's good too.
And if I mispronounced your name, please shoot me an email. I will correct it the next time we record one of these. Thank you.